Today, I'll talk about the anatomy of articular branches of the shoulder joint and no block technique for chronic shoulder pain. Please let me briefly introduce myself and my clinic. When you walk inside my clinic, you will face a big tree in the waiting room. There are well-trained 12 staff and work together systematically. I'm the only doctor in my clinic. I believe I have one of the most efficient pain clinic systems in the world. I had training as a radiologist a long time ago, but now I have been working as a pain physician for 21 years. I try to make a balance between practice and research. As a pain physician, I try to provide better and high-quality treatment for my patients. I have developed a simplified diagnosis and treatment according to evidence-based medicine. I have been doing image-guided intervention since I started the pain practice. There is no blind technique in my clinic. I applied ultrasound in the cervical spine intervention since 2005 and published ultrasound-guided intervention in the cervical spine in 2008. I have adopted a new treatment if it is proved good. I discarded it if it was proved not well. I have been working to make an infection-zero clinic with my staff. All the procedures have been done in the surgical room in a sterile condition. All the images were digitalized and saved for the future. The reception desk and counseling room staff are ready to explain all the disease, procedures, and prognosis. I let my staff regularly call my patients. Follow-up calls have established close rapport, monitored the pain procedures, and got feedback. I have had the result of each procedure and interpreted them to develop a better treatment. They are busy all day long preparing 60 procedures a day. The education became a driving force for building respect and being a new culture in my clinic. We have a conference every Tuesday after work. In shoulder joint pain, every pain practitioners talk about the benefits of ultrasound-guided suprascapular nerve block. It has become an important procedure in chronic shoulder pain. It covers acute and chronic pain. It has been used for control of postoperative pain after open or arthroscopic shoulder surgery. In chronic pain, it may be both diagnostic and more commonly a therapeutic procedure. Many chronic illnesses have been reported to use suprascapular nerve block, including rheumatoid arthritis, osteoarthritis, frozen shoulder, and persistent rotator cuff lesion. Pulsed radiofrequency of the suprascapular nerve have been used in intractable cases. When I read the articles about the suprascapular nerve block, it looked like I may fall into the illusion of a magical treatment for chronic shoulder pain. But I'm a very skeptical and stubborn pain physician. I believe it has been overestimated. I'm going to argue against a single suprascapular nerve block and break the hallucination. My first counter-strike logic is that the suprascapular nerve does not cover all the glenohumeral articular surface. According to an anatomic study, the suprascapular nerve covers only the upper posterior quadrant of the glenohumeral joint articular surface. It covers only the area of the supraspinatus and infraspinatus tendon and underlying joint capsule. The anterior superior part is supplied by the articular sensory branch of the subscapular nerve. It covers the area of rotator cuff interval, superior anterior labrum, biceps, subscapularis, and underlying joint capsule. The anterior inferior quadrant is supplied by the subscapular nerve and axillary nerve branches. The posterior inferior quadrant is supplied by the axillary nerve. There are many pathologic entities of chronic shoulder pain. For example, inflammation and fibrosis of the frozen shoulder occur in the coracohumeral ligament and anterior inferior joint capsule. This area is not covered by the suprascapular nerve. This area is innervated from the subscapular nerve and axillary nerve. If the nerve block is effective to relieve the pain, I must block the appropriate nerve or all the nerves that cover the area. Most of the shoulder pathologies take part in upper half of the glenohumeral joint. It is worthy of studying the articular sensory branch of the suprascapular and upper subscapular nerve. Let me review the suprascapular nerve first. The suprascapular nerve arises from C5 and C6 nerve roots. It originates from the superior trunk of the brachial plexus and moves toward the suprascapular notch. It passes underneath the transverse scapular ligament. It is a schematic drawing of the suprascapular fossa that I want to talk about. After entering the suprascapular notch, the main suprascapular nerve gives off the medial trunk and lateral trunk. The lateral branch becomes the main branch, passes the sphenoglenoid notch, and supplies the infraspinatus fossa. The medial trunk arises from the main suprascapular nerve after entering the suprascapular notch and supplying the supraspinatus muscle. The articular branches originate from the lateral trunk and main nerve before the transverse scapular ligament. Let me go further. This illustration and model are a bird's eye view of left shoulder. I built the suprascapular nerve branches on the model with the colorful metallic wires to study. I followed this anatomic study proven by Dr. Philip Ping. It is my model of a suprascapular nerve. It is the lateral trunk of the suprascapular nerve. It is the medial trunk. The purple wires are articular branches, and they arise from the lateral trunk. Let me review the suprascapular nerve anatomy of the original article. The clavicle was supposed to be here. I will remove the clavicle. Let me remind you the bony landmarks: coracoid process, acromion, scapular spine, supraspinatus fossa. The blue curve is the suprascapular notch. The green curve is the sphenoglenoid notch. Let's draw a connecting line between the suprascapular notch and sphenoglenoid notch and mark a red dot in the midpoint of the line. The suprascapular nerve runs underneath the transverse scapular ligament and then split into the medial trunk and lateral trunk. The distance of the bifurcation from the midpoint was about 1 cm. Keep the number in mind. It means that if I put a needle to the lateral to the suprascapular notch, I can spare the suprascapular motor branch. The lateral trunk courses along the floor of the supraspinatus fossa to the sphenoglenoid notch. The glenohumeral joint capsule is innervated by the articular branches that originated from the lateral trunk. Let's close look at the cadaver dissection image of the suprascapular fossa. I heard that it took 80 hours for one cadaver dissection. This is the innervation of the superior posterior quadrant of the glenohumeral joint. It is the clavicle shadow. The clavicle was cut. It is the anterior direction. It is the lateral direction. Note the coracoid process, acromion, scapular spine, transverse scapular ligament, and underlying suprascapular nerve main trunk. The blue color bars indicate the articular branch of the glenohumeral joint. The articular branches to glenohumeral joint originate from the lateral trunk. The articular branch is not a single branch. It consists of many branches. These articular branches run over the convexity of the lateral suprascapular fossa underneath the suprascapular muscle. These areas are the new target for the articular branch block. Second, let me review the upper subscapular nerve. The upper subscapular nerve arises from the posterior cord of the brachial plexus. It supplies the upper subscapular muscle and penetrates the muscle. The terminal articular branch runs underneath the subscapularis at the base of the coracoid process. It is my model of the upper subscapular nerve. The purple wires the articular branches of the upper subscapular nerve. The nerve is placed in the 1 o'clock position of the glenoid and anterior superior aspect of the glenoid. It is important because there are many pathologies in the rotator cuff interval and upper subscapular muscle. Let's review the innervation of the anterior surface of the glenohumeral joint of the original article. The dissection image is the anterior view of the scapula, glenohumeral joint capsule, humerus head, and proximal humerus. Note the subscapularis, coracoid process, long head of biceps tendon, posterior cord, axillary nerve, and radial nerve. The subscapularis muscle and tendon run underneath the brachial plexus and its main branches. The brachial plexus is closely located from the anterior glenohumeral joint line and subscapularis tendon. I may accidentally injure the brachial plexus if I puncture the anterior joint. Let's go to the articular branches. The upper subscapular nerve and axillary nerve innervate the anterior and inferior joint capsule. Purple color bars indicate the upper subscapular nerve. The upper subscapular nerve locates consistently on the anterior superior joint capsule. Close observe the subscapular nerve in relation to the coracoid process. It is located medial to posterior to the coracoid process. Let's look at the other dissection image. It is brachial plexus. It is coracoid process and clavicle. It is the upper subscapular nerve. It demonstrates proximity to the coracoid process. The dominance of suprascapular tendon pathology is the surgeon's perspective. In my clinical experience, the superior anterior part is equally important as the posterior part. I am stretching the articular branches of the suprascapular and upper subscapular nerve. As a pain clinician, I wanted to know the correlated sham anatomy of the articular branch of the suprascapular and upper subscapular nerve. Note the lateral trunk of the suprascapular nerve. I put the needle on the lateral aspect of the suprascapular fossa for the articular branch block. I simulated the needle approaches to the articular branches in a model under CM guidance. This is the model simulation of the needle approach to the upper subscapular nerve. And then put things together under CM guidance and measures the CM angle. I found that true AP view of the scapular bone and Y view is a very optimal CM view for each procedure. For the suprascapular articular branch block, the needle target is here in true AP and Y view. For the upper subscapular articular branch block, the needle target is here in the true AP and Y view. And then applied these procedures for the patients with the intractable shoulder pain. We published the effectiveness of the new nerve block technique and results in the medicine. Let me describe my patient. She is 82 years old and has had chronic intractable right shoulder pain. On physical examination, she showed a capsular pattern of limitation and pain. Let the patient spine oblique position. Support the body with a wedge block. Putting the support to the back will help her stay easy. After cleaning the surgical site, cover the area with a sterile drape. Adjust the CM to true AP view to the scapular bone, not to the patient's body. I'll use a spinal needle. Bend the needle tip using sterile gauze. It helps to control the needle. I'll go from the suprascapular articular branch first. Before inserting the needle, palpate the bony landmarks. Find the notch between the clavicle and scapular spine. Rotate and adjust the CM until you find the clear bony landmarks on true AP view. Puncture the skin on the medial edge of the acromion, clavicle scapular spinal angle. After putting the needle, watch the needle's direction. The needle aims toward the 1 cm medial to the superior lateral edge of the scapular glenoid and advance until it contacts the scapular bone, which is the undersurface of the suprascapular fossa. While moving, I have to keep in mind the anterior posterior and medial lateral direction of the needle. I try to align the needle with the anterior border of the scapular spine. There is something wrong. Do you know what happened? This is an illustration of how I did before. The needle overpassed the supposed cortical line of the floor of the suprascapular fossa because my needle went too posteriorly. Let me show you the Y view. According to Y view, my needle went posterior from the target. This time, I went to anterior and went to medially. Let me adjust the needle. I will confirm with contrast media. It is more likely the correct place. AP view shows the contrast spread of the bony surface to the articular side. Let me deliver the mixture of long-acting local anesthetics and dexamethasone palmitate. Please be sure to use the lower lock type of syringe. It can prevent water leakage in advance, as if it were exploding due to the loss of the syringe connection. Let's go for the upper subscapular nerve block. Remove the supporting block and let her in a spine position. I need a CM-AP view. In the first few cases, I insist on the true AP view. Note the coracoid process. Tilt the CM to open the space from the coracoid process. I'll put a needle on a slight right oblique CM view. Recently, I realized that the AP view of the body provides more safety from the brachial plexus injury. If I put the needle on a true AP view to the joint line, I may have more chance to injure the brachial plexus. The needle goes from lateral to the medial posterior direction. After needle touches the bone, the CM rotates to obtain the scapular Y view to visualize the subscapular fossa. I aim to the retrocoracoid space, just medial to the articular margin, and 1.5 cm inferior from the upper margin of the articular process. Advance the needle until it touches the bone, and then rotate to true AP view. Give me a Y view. Looks good. Let me confirm with contrast media. It is the contrast pattern on Y view. The contrast pattern is good. Watch the contrast pattern on true AP view. The contrast spread along the anterior surface of the glenoid. I put in a mixture of bupivacaine with dexamethasone palmitate. Thank you for your cooperation. Good job. My second argument is that does the peripheral nerve relieve the structural pain in the shoulder joint? In the tennis elbow, there are so many articles on direct interventional approaches to the tendon, including many favorable reports of regenerative treatment. I rarely find a few cases of nerve block or neuromodulation technique. Why so popular in the shoulder joint only? The age group of intractable pain in the shoulder joint is older than elbow tendon pathology. In tennis elbow, there is a high probability of regeneration by many factors. In the shoulder pain, the background is severe osteoarthritis and tendon degeneration, and of course, has a high probability of worsening. We need to lower the level of expectation. All these structural abnormalities make us easy to jump to conclude it as nociceptive pain. The authors reported about 10% of possible neuropathic pain in the rotator cuff tears. These authors also shows about 15% of prevalence of neuropathic pain in patients with full thickness rotator cuff tears. A nerve block or neuromodulation could be a logical option for the treatment of chronic shoulder pain. It is my hunch. The success rate of pain relief with a standard suprascapular nerve block depends on the rate of combined neuropathy. Articular branch block is better than the standard suprascapular nerve block. No chance of scapular nerve damage. The target is closer to the painful irritated nerve or structural damage, which is placed in the periarticular area. A mixture of steroids will relieve the inflammation more effectively. Like rheumatoid arthritis, the inflammatory pathologies are placed in the periarticular lesion in the shoulder joint. It is safer than standard technique. The target is far from the main nerve trunk, so there is no chance of suprascapular nerve damage. In this study, I applied CM to the nerve block. I'm working on the ultrasound-guided technique. In the future, I can show you the new technique. Thank you for watching.